introduce you to Cliff Douglas, who is an adjunct professor at the University of Michigan School of Public Health. And Cliff, before you get into things, I know I've told you this before, but I can't thank you enough for doing this. And I know that when you talk, a lot of times your meetings are focused on smoking from a cancer perspective, but not necessarily as often from the perspective of, hey, there's a higher relapse rate associated with smoking. So if you're battling an addiction, we want you to know that. And I want to throw out this caveat that recovery isn't a linear progression. It isn't perfect. And we're not here to preach that everybody should quit smoking, okay? In fact, we want to just provide you with options if you decide to smoke while you're in recovery or whenever. And the main thing we want to do, though, is educate so that, again, you've got these arrows in your recovery quiver that you can leverage. You're going to hear about more of that from Elena. You're going to hear from Dr. McChristian about the data to support what I just said on there is this higher relapse rate associated with smoking. So with that, Counselor Douglas, thank you so much for being here tonight.
Well, thank you, Mario, very much. You couldn't be more gracious. You're an amazing host. You're a terrific leader. It's been an honor getting to, first meet you and get to know you over recent months. And I know there are a lot of people here who share appreciation for your deep personal commitment, the warmth and generosity you bring to all of this, to these challenges that folks are working on themselves and with their families, and also for sharing your own story with everyone. It's incredibly moving. It's important. You're just bringing everything to the table here, and thank you. And I also want to thank Washtenaw fan and all of you who have been able to join us this evening, or for those of you in the future who see the recorded version, which we will have out soon. And also my fellow speakers, Caravella, McChristian, and Elena Williams. Thank you both for being here with us today. I just want to be sure that we have the video available. Brandon, thank you for your all of your technical support here. And will I be bringing up my own slides? Is that how we'd like to do it, or can you pull them up for us? I just want to be sure we do it the right way.
Yeah, just feel free to bring them up for the main part of the presentation, and then when we get to the video, I'll switch it over.
Gotcha. Okay, so let me just pull these up for us and make sure that I share screen correctly. I'm of a generation where it's still a challenge for me to get all of this done just right. So I think we're on share, and I'm going to switch over here and make sure that we're all good. So are we nice and visible, folks?
We are.
Okay. Wonderful. So this is a special event, and I count myself as very fortunate to be able to work with you all, to work with Washtenaw fan and my colleagues here at home. But I know that we have some folks tuning in from around the country, and this has particularly local, but also national relevance. So, thanks for joining us. So let me just begin by recognizing an extraordinary community of organizations, including some federal government agencies who have joined in coalition to address the destructive connection between smoking and mental health and substance use. It was about 6 years ago that I was honored to found this National Partnership on Behavioral Health and Tobacco Use, along with Dr. Steve Schroeder and his Smoking Cessation Leadership Center at the University of California, San Francisco. And it's dedicated to, with its 24 members, it's grown in recent years, to serving the joint interests of these behavioral health organizations, public health groups, medical and tobacco control groups, voluntary charitable groups and agencies, who are all dedicated to educating folks about the types of issues that we're discussing today and supporting meaningful change to improve health and prevent relapse and save lives. So, with all of this said, at the end, I'll provide some contact information at the end of the talk and invite folks to check out our resources, and please do be in touch. So with that said, I'm just trying to move it forward here. Let's see, there we go. I'd like to kick things off by sharing a short 2-minute video that Brandon is graciously going to help me with the technology. This was just released a couple of weeks ago. It's been circulating on Twitter, and I've chosen to include it here because in a few very brief words, this fellow who you can see, Dr. Matt Evison, who's a British lung cancer and tobacco dependency specialist, captures some really fundamental points that I think we should all be aware of. So Brandon, please go ahead.
Smoking tobacco is unique in the level of destruction it can cause in our bodies. There isn't a part of the body that escapes it. So although I see patients with lung problems, they also have all the additional problems of smoking. It damages every single organ in the body. There's some remarkable healing that happens in the lungs when you stop smoking. So many people that smoke will say they've got a cough, and they cough up things from the chest. And they often say, when I stopped smoking, that cough got worse, which is actually a sign of the lungs getting better. Well, you immediately start to get rid of some of the poisons that are running around the body. Carbon monoxide is a really good example. That happens within 24, 48 hours. You start to lose that poison from your bloodstream. What a lot of smokers don't know is that nicotine is harmless. When you burn tobacco, it creates a poisonous fume of chemicals. They cause the harm, not the nicotine. So why not get nicotine from either a safe source or a dramatically less harmful source? And that's through having nicotine patches and gums and sprays, very safe ways to replace it. And vaping is proving a very, very effective way for someone to move away from tobacco with dramatically less harm. And we have medications that actually work in the brain to block the effect of nicotine. And if you combine that with the support of a specialist that can help you change those deeply ingrained habits, those two things together give the very best success rates. The healthcare service are here to help them with this really deadly disease. And there is nothing that they could do that will make them healthier or wealthier from stopping.
I am going to be commenting more on nicotine, and it's central to this story. One thing that you heard from Dr. Evison was he said that nicotine is harmless, and I just want to explain that for a few seconds, and then we'll be talking in greater depth. That's not something you typically hear. What he's thinking of there, I think, in part, is, for example, here in the US, the Food and Drug Administration regulates nicotine-based cessation medications like gum and patch and inhaler. And they regulate them and approve them as both effective and safe. And again, those are drug, based medications with nicotine. Nicotine in certain clean forms is essentially harmless, with a caution that people who are pregnant, and Elena Williams can talk more about this later if she chooses, shouldn't use nicotine because of potential complications involving pregnancy. But apart from that, what he said, I think, is quite clearly accurate. Now, what he highlighted very importantly is that the 800-pound gorilla in what we generally refer to as the tobacco epidemic is cigarette smoking. And there are other tobacco products that can cause harm, but the act of burning and inhaling these substances adds magnitudes more harm. Every single one of the 480,000 annual deaths reported from tobacco use in the US, so every single year, or about 1,300 a day. And this is reported by the US Surgeon General and the Centers for Disease Control, is caused by smoking and or chronic exposure to secondhand tobacco smoke. And the impact is so severe that when you add up all of the prominent causes of premature and preventable deaths that you see here on the screen, including from opioids, which in recent years we added down in the right-hand corner, the combined toll is less than that from cigarette smoking all by itself. So for this reason, the Surgeon General in 2014, as part of his 50th anniversary report, the very first one famously was issued just after the assassination of President Kennedy, way back in 1964. They determined and announced as official policy that the primary target of tobacco control should be to end the unnecessary suffering and premature death that's caused by cigarettes and other combustible tobacco products. And this is something that we likewise emphasized in a report that I led at the American Cancer Society in 2018, which I chose to cite here. So, it's important to recognize as well that our historic efforts to combat the tobacco epidemic have also brought success. It's an interesting sort of paradox in our field of tobacco control. This is a winnable fight, and I really deeply hope that all of you will be part of our winning this fight. The adult smoking rate was 42% in 1965, and adult smoking has fallen a lot since then, as you can see here. And the consequence of it falling from 42% then to about 12.5% in the most recent data is the saving of about 10 million lives. We averted about 10 million deaths that otherwise would have occurred in this country from cigarette smoking if the rate in the mid-60s persisted until now. So, and you're going to note here as well that, the adult e-cigarette vaping rate, and that's something I'm going to be talking some more about, while already low, has also been falling. But again, reflecting that paradox that I referred to, we still have nearly 31 million adults smoking in the United States of America now. So while we've made great progress, why does the epidemic persist? Very obvious question, right? Well, there are several reasons, but the one that rises above all others is the addictiveness of cigarettes. It was back in 1988, you see an image of the cover of the Surgeon General's report from that year, when for the first time as an official government finding, the Surgeon General announced that nicotine is addicting when used in cigarettes and some other forms of tobacco. And the report found that, in fact, the addictive effects of smoking, in particular, resemble those of illicit drugs such as heroin and cocaine. It acts on the brain and sections of the brain in a similar manner. This was consistent with what the tobacco industry itself had known for many years, and I mean many years, dating back at least to the early 1960s, so like a quarter century before this, based on secret internal research that we only found out about later when the manufacturers were legally compelled to disclose what they knew. But publicly, they said things like this. So here you see a quote from the president of Philip Morris, and this is in 1997. Philip Morris is the largest private cigarette company in the world. It's the maker of Marlboro, which may still be the leading consumer product sold in the world. And he said this with a straight face, under oath, in a lawsuit against his company. In response to the question, do you believe that cigarette smoking is addictive? He responded, pharmacologically, my answer is no. If they are behaviorally addictive or habit forming, they are much more like caffeine, or in my case, gummy bears. I love gummy bears, and I want gummy bears, and I like gummy bears, and I eat gummy bears, and I don't like it when I don't eat my gummy bears, but I'm certainly not addicted to them. Folks, president of a Fortune 100 company making the leading consumer good in the world with tens upon tens of millions of customers in this country and around the world. All right, so here's the harsh reality that we came to understand. And Mario, I appreciated you talking a little bit about some of my background over the few years I've been doing this, which started in 1988. It was right around the time of that nicotine addiction Surgeon General's report. My first major effort in tobacco control, I'm still thrilled to share with folks, was to help coordinate the national campaign to remove smoking from airplanes. So for decades, the major cigarette companies have employed sophisticated technology that they never say anything about publicly, even today, to engineer their products for addiction. They pretend that the cigarette is just another agricultural product with regular old, farm-grown tobacco just rolled up in paper and burned. But in fact, they use blending techniques, chemical additives, genetic engineering, and billions of dollars worth of manufacturing technology to precisely control the delivery of this drug through the cigarette, which is in essence a dirty needle. We first broke this news to the public in an expose on ABC News back in 1994, which I brought to the network with the help of a tobacco industry whistleblower scientist I represented and codenamed Deep Cough. Her real name has never been disclosed publicly, and she appeared on TV with her face obscured and her voice mechanically altered, as she was afraid, for good reason, of facing retribution from her company. But she courageously worked with us to share the truth, and we have a lot to thank her for. I refer to the cigarette as a dirty needle. When lit and combusted or burned, cigarettes produce smoke containing 7,000 chemicals, count them, 7,000 chemicals, including more than 60 known human carcinogens or cancer-causing substances. And through the manufacturer's manipulation of the cigarette, many users quickly develop dependencies to this toxic mixture. And of course, the vast majority of smokers we know start as adolescents, long before they're of an age when they're making a potentially rational decision about whether to use a product that kills 1 out of every 2 long-term users. So take example number 3 here. You can see referring to ammonia chemistry. In the 1960s, the companies discovered that when they added ammonia as an ingredient, which they said they used for flavor, by the way, when cross-examined about it in testimony. We're talking about something that's used as a toilet bowl cleaner. But when they included it in the cigarette, it acted synergistically with nicotine to speed the delivery of the drug from the lungs to the bloodstream to the brain and central nervous system, which causes a freebasing effect, much like the difference between crack and powdered cocaine. And this enhances, and I don't need to say it at this point, I'm sure you get, but quite deliberately, the addictive impact. And of course, it enhances the company's bank accounts. So there's also another twist that you should be aware of, and it's important. While nicotine fuels the epidemic of the use of the leading preventable cause of death, cigarettes, it isn't itself, as I touched on earlier, the cause of the illnesses produced by inhaling smoke. And this is the subject of a lot of misunderstanding. Think about it. If you think that nicotine causes these illnesses, you're going to be deterred from using Nicorette or Nicoderm, right? That are there approved as safe and effective by the FDA, designed to help you quit smoking. And you may be afraid to use them because you think nicotine in those products is going to harm you. And in fact, that does happen. We learned in research in the last couple of years that about 80% of physicians, so don't feel bad if you misunderstand, incorrectly believe that nicotine causes cancer. And about 61% of smokers similarly believe that nicotine causes cancer, or say at least they don't know. So, a couple of words about this related topic, the delivery of nicotine by non-combusted products, such as what are called e-cigarettes. E-cigarettes are part of a broader class of devices known as electronic nicotine delivery systems, or the acronym is ENDS. They're battery powered. They come in many forms and deliver nicotine aerosol, which folks commonly refer to as vapor, but it's not water vapor, so I choose to use the scientific term of aerosol. But it isn't smoke, and it does come along with some varying levels of other chemicals. E-cigarettes have been found by a strong consensus to be substantially less harmful than cigarettes, than combusted products. And in the UK, for example, you heard from Dr. Evison, are used both for harm reduction and smoking cessation. The same is not necessarily true in the US. Different governments and health agencies around the world are continuing to wrestle with the complexities around this, and in part concerns around youth access to these nicotine delivery devices. That's quite a legitimate concern, but we're talking at the moment here about the relevance to adults, and particularly in this context, those who may be in recovery. So in the US, the National Academies of Sciences, Engineering, and Medicine, or NASEM, found in an exhaustive report that e-cigarettes can reduce harm. This chart provides a glimpse of what the FDA refers to as the continuum of risk, on which all tobacco and nicotine products fall, ranging from cigarettes all the way at the most dangerous end. You can see it on the left. And then nicotine medication all the way on the far right, where it refers to the patch. And then everything else falls somewhere in between. And as you can see, at least in this depiction, ends are shown to be far less harmful than a number of combustible products. You'll see that following cigarettes, you'll see small cigars, pipes, cigars, water pipe, or hookah, for example, and then other products fall further down the spectrum along that continuum. So, importantly, I noted that there are about 31 million people in the United States who are still smoking today. Who are they? The majority of smokers today are socially marginalized. They tend to have lower income. They tend to have fewer years of education, live with mental health or substance use conditions, and/or are members of the military or veterans. Individuals with mental health conditions or substance use disorders represent about 25% of the US population, and yet consume about 40% of all of the cigarettes sold. And about half of the 480,000 Americans who die each year from smoking are individuals with a behavioral health condition. So I'd like to thank our colleague, Doug Tipperman at the Substance Abuse and Mental Health Services Administration, or SAMHSA, for this graph. When it comes to smoking and substance use, there's a very large difference in smoking rates between those who do and don't live with SUD. While there's good news in that both have come down significantly, as you can see here, in recent years, more than a third of people today with SUD were still smoking as of 2020. So for this image, I want to thank Dr. Steve Schroeder and our colleagues at the Smoking Cessation Leadership Center at UCSF. What it makes clear is that smoking by those with behavioral health conditions, including substance use and those in recovery, for those people, smoking matters a lot. Persons with mental illness on average die several years earlier than persons without mental illness, with smoking being a major contributing factor. Smoking tobacco causes more deaths among people who had been in substance use treatment than the alcohol or drug use that brought them to treatment in the first place. People who continue smoking following treatment for substance use disorder have much greater likelihood of relapse. This is all based on extensive research. Smoking is associated with increased suicidal ideation and suicide attempts and completed suicides. Daily tobacco use is associated with increased risk of psychosis and an earlier age of onset of psychotic illness, and heavy smoking is a significant risk factor for major depression. So, as you can see here, one of SAMHSA's surveys found that smoking prevalence for those 12 and older who received substance use treatment was 74%. This is a few years ago now, so one hopes the number is lower, but you get the picture of the magnitude of the challenge. Just returning to the issue of the industry's culpability, I'm going to ask Brandon again for a little assistance to show us a very brief video created by the Truth Initiative.
Do you think that tobacco companies targeted people with mental health issues?
If you look back through the documents, they go after people with mental illness, people with depression, people with anxiety. You have this subversive marketing saying you have a problem and we have a solution.
Because you see that it's considered normal or okay. And that's where I would turn to cigarettes and be like, oh, I'm stressed out, so let me smoke a cigarette.
It's despicable.
Big Tobacco went as far as giving free cigarettes to psychiatric facilities.
It's essentially a big bully preying on the weak.
The consequences of this targeting are horrific. People with mental health or substance abuse issues account for 40% of the cigarettes smoked in the United States. And this is one of the leading reasons that people with mental illness die about 5 years earlier than those without.
I'm livid. It's sick. It's twisted.
You're just gonna have to stand up to make the change.
Don't give up. Don't give up the fight.
Know the truth, spread the truth, finish it.
So, you know, what the industry has done over the years, as you just saw a snippet of, in addition from the Truth Initiative, which produces really fantastic ads, is contribute to and promote a norm of smoking by people in substance use treatment. And that norm is reflected in this piece from our colleague Dr. Joe Gaidish, whom Mario noted earlier, who again is Dr. McQuistion's mentor, who you're very fortunate to hear from next. He wrote for this piece published by CNN. A year ago, I had a call from the father of a young man who was enrolled in a residential drug abuse treatment program. During his visits, the father noticed that the program gave a carton of cigarettes to residents every 2 weeks as a reward for progress. This is where the smokers are. They're in our addiction treatment programs, in our mental health treatment programs, and in our criminal justice system. And as you're going to hear more about, you know, the encouraging news around all of this, which is very real, is that as stated by this landmark report, yet another one from the Surgeon General focused on smoking cessation, there they wrote, quitting smoking does not jeopardize the success of treatment for mental health conditions or substance abuse and may actually enhance recovery outcomes. What a critical message. Additional research since then, I can tell you, has further confirmed this. So I'll just leave you with this thought, and you're going to hear some more about it, because this gets to the areas of some of the things that we can do and really do need to do. I implore you. We must do better together. A lot of improvement is needed in the delivery of smoking cessation treatment and the adoption of smoke-free policies within substance use and mental health treatment settings. Doing all of that changes the norms around smoking, helps educate people, it helps people quit. It improves, in general, overall treatment outcomes, and it protects everyone against exposure to harmful secondhand tobacco smoke, which I may not have noted specifically before, is itself the third leading preventable cause of death in America. Direct smoking by smokers themselves is number one. So together, it's an incredibly toxic mixture and outcome. So I want to thank you at this point. Look forward to talking to you more for your attention. You know, again, Mario, thank you for bringing us together in this, you know, truly important session. I'm really honored to be part of it, and I look forward to your thoughts and your questions later in the meeting. So with that, I'm very pleased to welcome Dr. McQuistion, who comes from, again, the University of California, San Francisco, which I'll tell you, even from the University of Michigan, UCSF is a hotbed of incredible work and service in this area, in the United States.
Yeah, and Dr. Joe Gaidish, Caravella, your mentor, correct? And how you came up in psychology. It's an honor to have you here. We're thankful to Dr. Gaidish for loaning us your expertise. Thank you for being here, and go ahead and queue up your PowerPoint.
Great, will do. Thank you so much. And thank you, Cliff, so much for that great presentation. I learned so much.
While you're bringing that up, everything, all of the PowerPoints, all of the resources that you can access for free from the University of Michigan Cessation program, the recording of this meeting will all be made available to everyone. I'm just answering one of those questions. So go ahead, Caravella.
Sure. So this is going to be a great kind of continuation with what we just heard a lot about related to how smoking impacts people who are in substance use treatment and some levels of intervention that can be implemented to help people who are in substance use treatment in their smoking cessation goals. So before I get started, as was mentioned, my name is Caravella McChristen, and I'm a postdoc at UCSF in the Department of Psychiatry and Behavioral Sciences. I'm also a clinical psychologist, and I work with Joe Geidish in developing, implementing, and testing interventions to help with smoking cessation, primarily among people who are in residential substance use treatment or inpatient substance use treatment facilities. So we've learned about this already today, but I just want to reiterate it because it's so important that tobacco-related deaths surpass deaths, tobacco-related deaths specifically for people who have substance use disorder and mental health, surpass those deaths for people who are in the general population. You can see here, this is actually data that is from Oregon. And what you can see here is that people with substance use only, or specifically people who are struggling with mental health and substance use issues, they have almost a little bit, almost twice as much as the general population when we look at tobacco-related deaths. And this pattern is seen across different age groups until you get to about ages 70 to 79. So it's pretty pervasive, this issue of smoking and how it's related to deaths for people who are dealing with substance use problems. And so that's why it's very important, as we've learned in our previous presentation, to do something to intervene in these issues. Again, as we learned before too, smoking cessation interventions are actually not really associated with negative treatment outcomes. In fact, we actually see the opposite. So smoking cessation is seen with a 25% increase in abstinence of other substances when people are able to quit smoking while they're in substance use treatment. And if they are continuing to smoke, that can be associated with increased risk of relapse to other substances. So, all of this information combined, that it doesn't, really have any negative treatment treatment outcomes. And in fact, it could be really related to more positive treatment health outcomes. This leads us to kind of think that substance use treatment programs really are kind of well positioned to reduce smoking among people who have substance use disorders. So that's good news because there's a lot of places that we could intervene for substance or smoking cessation for this population. But the problem is that we're just not doing it at the rate that we should. So you can see here overall, these are different types of smoking cessation services that could be offered in substance use treatment programs. For example, screening all of the clients who access services, if they smoke or not, providing those clients who do smoke some counseling on how to quit, offering nicotine replacement therapy or NRT for people who are smokers, which is evidence-based to really support smoking cessation. We heard about that in the video earlier. Other non-nicotine pharmacotherapy like Chantix, or offering tobacco-free grounds, meaning that tobacco use is not allowed by staff or clients on treatment grounds. These are all evidence-based approaches to smoking cessation that we know work. But as you can see here overall, only 64% of clients are being even screened to know if they smoke or not. And then only 26% of those are receiving NRT. And then 34%, only 34% of substance use treatment programs are tobacco-free. So that means the remainder allow smoking for clients and or staff on treatment grounds. I'm from California. Most of our work is here. So I always like to show that we are not doing much better than the overall population. You see here 21% tobacco-free, or I'm sorry, 22% tobacco-free grounds. NRT is at 20%, and we're screening only about a little over 50% of clients who come to substance use treatment. And I pulled the data also from the paper here for Michigan, and it looks like Michigan's doing a little bit of a better job at screening people, a little bit about similar with NRT, and then a little bit higher on tobacco-free grounds, which is good news. But again, these numbers are much lower than we would want, given that smoking, is so prevalent among people who are accessing substance use treatment, and substance use treatment is really kind of well positioned to address this issue. Despite it being well positioned, though, there are some reasons why a lot of programs decide not to offer smoking cessation services or go tobacco free. These are some quotes from a qualitative study that we did back in 2016. And it was a series of interviews from program directors from residential substance use treatment facilities. And you can see here, there's a lot of quotes that relate to why people just wouldn't want to implement smoking cessation or tobacco-free grounds. So you see here, program directors are saying, it's not a part of the culture. It's not one of the reasons that clients knock on our door. Clients may choose not to come here or even leave treatment if we are tobacco-free. A lot of clients don't have the funding to pay for their own NRT. We try to encourage people to stop smoking, but when staff's outside smoking, it's kind of hard, which is pretty common. Staff smoking rates are higher than the general population in substance use treatment facilities. And then you don't want them to quit everything at the same time because it just puts too much stress on clients. And we've learned already, hopefully from the presentations today, that there's some data that shows that that's not necessarily true, and that smoking cessation while in treatment can be done and can be done safely and can actually help treatment. But these are some of the reasons people may not want to implement it. But on the flip side, there's also some potential benefits to implementing tobacco-free grounds and offering smoking cessation services in treatment. So again, this is the same data from similar program directors. And you can see here that they're saying, despite those consequences, people who quit smoking have a better chance of staying quit from other drugs and alcohol. And that's what we do here. We do treatment. So why not implement treatment for smoking cessation as well? If we're working on whole person education, we really need to figure out how we can assist them in quitting tobacco too. This is something we hear a lot from our partners who are program directors, is that it's important to focus on the person holistically when they're in treatment. And if we're going to be doing that, then we need to focus on smoking as well. Another benefit is that we want outdoor space for alternative activities like walking paths, and to allow folks to participate in alternatives to smoking. For those of you who are familiar with residential substance use treatment programs, there's, the ones that I'm familiar with here in California, there's not a lot of outdoor space. Oftentimes that outdoor space is reserved for things like smoking. And so there's not a lot of things that clients can do specifically outside to socialize other than smoking. So again, that's another way it's reinforced. And not allowing smoking in these sites can offer up space for more activities. Another reason that programs may want to start implementing tobacco services is that this is just too much energy, too much of like, can I go smoke? And that kind of leads this program director specifically to say, okay, that's enough. We're just going to go non-smoking. So there's not the distraction of people wanting to go smoke. And then also, which I'll talk about in a moment, there are some states who have implemented policies to reduce smoking in these settings. So you'll see here another benefit is that the state was pretty clear about, we're going to help fund your program, but you can't allow clients to smoke there. And that's one of the kind of legislative approaches to implementing tobacco services in these programs that I'll talk about here in a second. So as I mentioned, there's different ways that we can intervene and reduce smoking and implement tobacco cessation and substance use treatment. I'm going to talk about each of these different levels. I'm going to share first, what are some approaches to tobacco cessation at the client level. So this is an outline of a project that we have right now where we implement a readiness to quit and smoking cessation group in residential substance use treatment programs here in California. So we're doing it now. The data is ongoing, but this data is from we did it earlier with just women who are in substance use treatment. And our group here is comprised of 3 readiness classes, which is what we kind of call the first 3 sessions you see at the top. We call them readiness because we really are all about kind of building motivation in these first 3 courses. These are all 60-minute classes that happen in person, or during COVID, they were offered virtually over Zoom. In the first class, you see we do things like build motivation about why people may want to quit, and we introduce them to what nicotine replacement therapy is. So tell them a little bit about the patches and the gum and the lozenges and the nasal spray. And in our second group, we talk about some strategies that people may want to use as they go through withdrawal from nicotine. And then we prepare for what we call a quit attempt. So right after the second group, the day before the third group, we ask people to use NRT that we've supplied and brought to the programs and put in their med boxes and provided for them so that there's no issues with them accessing it. We ask them the day before the third group to just try to use that medication, and try to use it in the place of smoking. And I think that this is a really important part of the group because a lot of people are hesitant to commit to quitting completely, which makes a lot of sense. But I think that people are willing to give an attempt to use these medications to see what it would be like to quit. So the third group is all about discussing how that quit attempt went. And I will tell you, I facilitate 2 of these groups right now weekly, and I am always impressed by how drastic the number of cigarettes changes from the quit attempt alone. I see people smoking, a pack or half a pack a day, and they'll use gum or patches or lozenges and come the next day and say they only smoked maybe 2 cigarettes that day, or maybe they didn't even smoke any at all. So I think maybe also the clients are always impressed with how well NRT works for some people. So once people do the 3 readiness groups, we then go into the cessation portion of the group. And this is about making more tailored plans for when people want to quit. And I appreciate Mario's point earlier that, we are not here to tell anyone that you have to quit. And I don't tell people that in our groups either. I really believe in that reducing number of cigarettes is also going to result in a less harmful impact on smoking. And I also think that smoking cessation happens over time. So throughout these 3 cessation groups you can see here, we do a lot of building motivation, of learning how to quit for life, how to reduce your smoking. We talk about the dreaded cost of smoking, which many people on this call may know or may have heard of. And we actually do talk a little bit about some of the ways to cope with the aftermath of quitting smoking. So how to deal with stress instead of turning to a cigarette, and how you might want to change your physical activity and nutrition behaviors as you quit smoking. So you can see here that there's this comprehensive group. And what we've learned through our data that we collect before people participate in the group and then after is that people who do those 3 readiness groups that I described, we do see a significant decrease in cigarettes per day. So people are going from, a little over half a pack a day to just about 7.5 cigarettes. We also see that people who participate in that readiness group are 2 times more likely to attend other cessation services. So that might mean that they're ready to go on to those cessation groups that I just mentioned, or it might mean that they're ready to go on to any other cessation services perhaps like calling your smokers helpline from your specific state. And people who are 6.8 times more likely to participate in cessation services if they made that practice quit attempt. So again, as I mentioned, I think that practice quit attempt is really crucial in getting people ready or open to the idea of quitting smoking. Okay, so I talked a little bit about what can be done at the client level. I'd like to now talk to a little bit about what can happen at the program level. So this is a project that we have done in partnership with the California Tobacco Control Program, CTCP, and also the Smoking Cessation Leadership Center, as we've mentioned many times today. So what you see here is that we evaluated a program where 7 residential programs here in California partnered with CTCP and SCLC, and they were provided $36,000 over an 18-month period to essentially create a policy that would assess and treat clients for tobacco use. And it also was supporting these programs and going tobacco-free. They were also provided funding and support to implement other wellness activities, such as things to help with physical activity and nutrition. And so what we found here is that across that 18 months, 5 of the 7 programs were able to implement tobacco-free grounds, which again is a great way for programs to support smoking cessation among their clients. And we actually saw some changes in smoking prevalence too. So what you can see up here in your top left-hand corner is that smoking cessation at the beginning of this project was about 54.2%. So 54.2% of clients smoked. And over the 18 months, as the programs were able to implement all of these policies and go tobacco-free, that almost cut in half. So smoking cessation was only 26.6% at post. And with that change, we see an associated increase in NRT being provided to clients. So NRT at baseline was only at about 12%, and that more than doubles here at 25.2% at post 18 months later. I always do like to point out though that there were some things that didn't change in the programs. You can see below. These really point to me to some of the other things that could happen in programs that maybe need a little bit more support that could help with smoking cessation. So tobacco counseling, for example, referring to quit line, putting quitting or smoking cessation in clients' treatment plan, screening, and then staff smoking. These are all areas for future work in the program. We also saw some significant changes on the staff side as well. So you'll see here, staff were significantly more likely to report that there's a tobacco-free grounds policy at post. They were more likely to report that they are receiving tobacco-related training, both at an interim 12-month data point and at 18 months. And this is huge because tobacco-related training and just not feeling like well-versed in how to treat tobacco is one of the reasons why we've heard kind of from staff, one of the reasons why tobacco-related services are not offered. And then you see here that staff are also reporting an increase in providing NRT to their clients here, both at 12 months and 18. And they're also reporting here, at least at 12 months, that they are providing more education and support to their clients regarding smoking cessation. So that's all good news. And this slide just kind of summarizes that. What I want to point out, though, that there are some of this data, the post data specifically, was collected during COVID. And one of the things that we noticed is that there was already a significant decrease in smoking prevalence for clients before COVID even happened. I think that's really important because a lot of people are unsure how COVID is going to impact smoking cessation and smoking prevalence for people in general, but specifically for people in substance use treatment. So we found that it looks like people were smoking because of these program level changes before COVID even happened. And so the summary is just basically providing these programs with monetary support or education or resources really allows them to develop these individualized policies that show promise in reducing prevalence. Okay, so for the last way that smoking cessation can be implemented into substance use treatment programs, I want to provide you with some data about what can be done at the state level. So you'll see here that there's several states that actually have implemented tobacco-free policies at a statewide level for any substance use treatment facilities or even behavioral health facilities. So you see here back in 1999, New Jersey implemented a policy that there can't be any smoking in residential treatment programs. And what they saw after that change is that all programs started assessing and treating for tobacco use. And 80% of those programs had treatment offered for smoking staff. And there was an increase in NRT being offered for clients as well. And New York implemented a similar policy in 2008. And they saw a pre-post decrease in client smoking prevalence, which was great. And Oregon as well implemented a similar policy, and the policy corresponded with increase in tobacco screening and increased referrals to the smoking quit line here. And California is implementing some policy efforts as well. We just saw an assembly bill passed in August 2021, and this is called AB 541 for short. And we're expecting that this will go into effect soon. And the bill actually asks that all licensed and certified California substance use treatment programs must first assess for client tobacco use among their clients. Remember, I said that was one of the big things that you could do for smoking cessation. All the programs need to educate clients about the harms of tobacco, many of the harms that we learned about earlier. And they must include tobacco cessation in treatment plans. So I think this is going to be huge in smoking cessation, or I'm sorry, in substance use treatment programs. Any of you that are familiar with them or work in them, if something's in a treatment plan, it has to be addressed in some way while a client is in treatment. So imagine if smoking cessation is in that treatment plan, how much attention that will get and how much services will be targeted towards that goal. And they also have to offer that treatment or a referral to services. So this is going to be a huge change for us here in California. There are some problems with it, though, that will kind of work out as the bill goes into effect. One is that there's limited guidance on what services should be offered. We see the guidance here above, but that could mean anything. For example, somebody could offer treatment by giving an educational handout. They could offer treatment by referring to the quit line, or they could offer treatment by offering that very comprehensive individual level group that I mentioned. So it could really vary. And programs are just now receiving a little bit more information about how to implement these changes. Another thing that may be an issue is that it doesn't prohibit smoking specifically. It doesn't require programs to go tobacco-free. And as you saw on the slide before, all of the other states that have gone tobacco-free have seen benefits of that. So this may be a limitation for our assembly bill here. And then the last thing is that we don't know yet if there's going to be any associated changes in smoking prevalence with this assembly bill. This is something that we'll be looking at moving forward, but it'll be good to know if smoking prevalence does decrease as this bill goes into effect. Okay, so just as a summary, this is our last slide, and then I'll move it to our next presenter. The recommendations at the individual level are that smoking cessation services and treatment services should be offered in any way as comprehensively as possible. If it can be a group that's integrated into treatment, that's great. But if it can be a referral to an outside source, that's also important. Programs can implement smoking cessation services specifically by adopting tobacco-free grounds policies. And then states can consider incentivizing tobacco services and treatment programs, and they can regulate that programs implement tobacco-free grounds, which would also help with smoking cessation. And that's it. I welcome any questions at the end.
Caravella, you've mentioned several times tobacco-free grounds.
Mhm.
Some of the places that I visit, and I visit a lot of these places across the country and in Michigan, they have tobacco-free grounds on premises, but that if you want to smoke, you got to go under the, umbrella at the park bench, okay? That's still on the grounds, but isn't inside. How do you define smoke-free grounds?
Yeah, thanks, Mario. That's a great question. You can imagine that if smoking's not allowed inside, but is allowed outside in the parking lot or somewhere nearby, that doesn't really deter people from quitting. So we define it as no smoking indoors or in any program property.
Okay, wow. Okay, well, we got a ways to go before that one happens. The places I visit, they allow, you got to go out there, to smoke. So anyway, thank you very much. We'll take questions after. I want to move right to our next guest speaker, which is, okay, now, how do I go about quitting? And that is Elena Williams.
So good evening, everyone. It's so nice to be here with you this evening. I do want to be respectful with our time. I can talk about support for quitting smoking for a very long time. So I'm going to try to breeze through my slides, but my contact information will be included. So if there's any support that I can provide or if there are additional questions, please feel free to reach out. Since this is a family forum and my connection with tobacco use and what brought me to this work is pretty personal, I wanted to start off by actually sharing some pictures with you this evening. And so this first picture here is actually me pre-COVID outside at the University of Michigan Hospital in the Cardiovascular Center's courtyard. And this was after a busy day of doing patient consults, meeting with people that are hospitalized for many of those tobacco-related preventable diseases that we've been discussing. And one question that I got, and I often get this question, is, have you ever smoked? I get that question pretty frequently when I'm working with people on quitting smoking. And I proceed with caution when I'm asked that question, because one, I know that there's a stigma around tobacco use, and I don't have a tobacco use history. So I don't want to create any distance or concern with the person that I'm working with that I may not understand the nature of nicotine addiction. We heard about how addictive it is, and I know that it's very hard to quit, but I don't have that personal connection to use. What I do have is a personal connection how tobacco use has impacted my family. So that second picture down there with the smiling faces is actually a picture of me, my mother there in the middle, and my two older siblings. I'm an 80s baby, so my Cabbage Patch doll is also in that picture. But this is actually one of my favorite pictures because we're all smiling. My mother actually started smoking when she was 13 years old. So she smoked all her life from that point, definitely used it as a coping mechanism to deal with some depression and some trauma within her life. And at the age of 48, she was diagnosed with lung cancer. During that time, I attended many appointments with my mother. I listened to oncologists really urge her to quit smoking, try to shame her to quit smoking. We were never offered support on how to actually do that. And this was at a time when I was in my early 20s. I didn't have the knowledge that I have now as an oncology social worker and a tobacco treatment specialist of what it actually takes to quit smoking. And it can take a lot. So needless to say, my mother did not quit smoking. We didn't get that support in that area. And she talked to me a lot about how hard it would be to quit at that time, where she was dealing with the most stressful thing in her life, a cancer diagnosis and cancer treatment, that the cancer eventually was a softball-sized tumor that spread from her lung to her brain, and she died a week before her 50th birthday. So while I've never smoked a cigarette, I have felt the devastating and deadly impact of tobacco use every day of my life for the last 15 years. This third picture actually is one of my favorite pictures, and that is my beautiful baby girl, Aria Michelle, named Michelle after her grandmother. And the one thing that I have learned on this journey of motherhood, as much joy that comes with it, there is a sadness as a motherless mother going through this journey without my mother, and knowing the impact that tobacco use not only had on my mother and me, but it also has an impact on my baby girl. So it's very near and dear to my heart. I have a strong desire to help people quit and find that hope to make the first step in quitting. And that's kind of where my journey along tobacco treatment and providing support for people started. So I thought I might share that this evening, given that this is a family forum. So with that said, one thing I like to do, whether I'm doing a presentation for providers or working with people that are trying to quit, is really define what we're up against. Cliff did a wonderful job of that, and Dr. McChristian also laid the groundwork where the support needs to be in place. What we're up against when we think about the addiction is huge, and we need that support. So I like to share this, that when we think about tobacco dependency and what treatment should be, tobacco dependency is a chronic relapsing disorder. Like other chronic diseases, it often requires repeated interventions and long-term support. And somewhere along the lines within healthcare and in substance abuse treatment, that is often lost. You didn't start smoking yesterday. There's no way that we should expect you to quit tomorrow. This is a process. And we know that the majority of people, including those with co-occurring substance use disorders, want to quit. But it also takes multiple times before success occurs. And that's also something to keep in mind, because it can be very frustrating putting in the work and relapse comes. Relapse is really a part of the game when we think about tobacco dependency and tobacco treatment and really providing comprehensive support. So I want that to be, I put that out up front. I share this with the clients and patients that I work with, and it's really along the lines of providing that hope that it can be done. It may take a few times, but that's okay. So we know quitting is a process. Mario said it earlier. It's not this linear thing. You don't start at point A and zip to point Z. It takes time. It takes a lot of support. And again, relapse may occur, but the important thing that we need to remember is having the correct support in place and making sure that we're being understanding and providing grace throughout this process. So this is something that I keep on my wall. Oftentimes I'll ask someone, like, where are you at right now in this process? And for many people, they're thinking about that change, thinking about quitting every day, but struggling to find out, where do I start? Most people don't quit without support. When we look at the research, it's about 7% of people that actually quit cold turkey. And if you meet someone that tells you they quit cold turkey, Ask them how many times did it take before they actually quit, because I'm sure that it's probably several. So just know that moving forward, whether you're working to quit or you're working with someone or have a loved one that is a tobacco user, it really is a process. And I would say the most important part of initiating this process is meeting people where they're at. One thing that I could do, I feel like anybody, wherever you're at in this process, we can have a conversation about your tobacco use. It's not just smoking a cigarette. It's so much more to that. We've heard about the addictive nature of nicotine. We live in a time where stress is high, supports and resources are not always easily accessible. So that self-medication piece that comes along with nicotine use is important. So I'll often ask, what do you enjoy about tobacco use? This is an important question. Most people probably have never been asked this. They've been asked, why do you smoke? Why don't you quit? But really getting to the root of what someone gets from the tobacco use can be really important and a really good starting point as we think about what do you need to help you, to guide you along this process of quitting. So I love starting with that point and realizing I don't want to come into your life and make suggestions about taking this thing away that has been there for 10, 20, 30, 40 years and not coming in with resources and support and coping strategies to replace whatever it was that you were getting from tobacco use. So if you're working with someone that's working to quit or thinking about quitting, just having a conversation around these 4 questions can be a really good place to start. The other really important question I want to just touch on really quickly is, what will you lose when you quit tobacco? This is also a really important question when we think about putting resources in play to prevent relapse and support that ongoing cessation. If you think about it, I talked about people smoking for 20, 30, 40 years. This is a relationship. It's not a good relationship, but many of us have been in not so great relationships. We know it's hard to get out of those relationships sometimes. So thinking about that relationship and how to break away from that is a way that we can frame quitting that people tend to connect with. I'm working with a woman right now who's been smoking for 65 years. She's 85. She's been married for 60. So this is a relationship that's longer than this really, really long marriage that she's had. One of the most important relationships in her life is her relationship with her husband. Yet when we look at her tobacco use, that relationship has been in her life longer than that. So it's really important how we approach quitting, and these questions can be a good starting point as we guide the conversation. When we think about preparing to change, given the nature of nicotine addiction, comprehensive tobacco treatment definitely addresses the biopsychosocial aspect of nicotine addiction. This is comprehensive treatment. Oftentimes, people have no idea what to expect when they come in for tobacco treatment. I think oftentimes there's a wall up where people feel like we're going to tell them how bad quitting is and how they should quit and that it's this easy thing. Tobacco treatment is far from that. Again, I am not here to get people to quit. Dr. McChristian talked about reducing tobacco use, which we support. Ideally, if we could get everybody to quit, great, wonderful. And we understand that's not the reality. So we want to meet you where you're at, address these different factors that contribute to the addiction, and develop a plan that really works within your life. So we look at that physical addiction. We heard how addictive nicotine is. Look at the psychological aspect of it, where there is some reward that we get from nicotine, and there's really not a stronger delivery system than inhaled tobacco smoke. Once you inhale, nicotine gets to your brain within 7 seconds. That is faster than a needle full of heroin. So thinking about that, knowing that the chronic relapsing nature of this disease and the impact of nicotine addiction is there, we have to address these things. And then also looking at the social lived environment where the tobacco industry spends billions of dollars on marketing. It's hard to walk out of our homes or go into a store without seeing the predatory practices of the tobacco industry. So all important things to consider: what your social circle looks like, if your family, is everyone a smoker, what that looks like, and how do you continue to have those interactions, because they're important, and doing it without tobacco use, which can be really hard. So these are all components of tobacco treatment that we put into comprehensive plans. When we think about quit planning, we do support quit dates, but understanding the idea of setting a quit date can, for some people, be stressful. So really, again, meeting people where they're at, making suggestions around gradual reductions, and Dr. McChristian talked about the benefits there. This can be really good when people are struggling. And we celebrate the small wins. So can you reduce your tobacco use by 20% 1 week? And what does that feel like? And then building upon that small win is really important. I'll talk a little bit about the medication for tobacco treatment, which is underutilized and underdosed and has some huge benefits when we think about nicotine addiction. And then also triggers and coping strategies are really important as we think about relapse prevention. There are 7 FDA-approved medications for tobacco treatment listed here. The first 3, the nicotine patch, gum, and lozenges, are sold over the counter, although I'm a huge proponent of, if insurance covers it, let's get it paid for. There are also free access to nicotine replacement therapy through state quit lines, which I'll talk a little bit about the Michigan Tobacco Quit Line later in the presentation. So with the nicotine replacement therapy, we know that it alleviates nicotine withdrawal symptoms, which is typically the reason for relapse, the desire to alleviate some of those nicotine withdrawal symptoms that can be very, very strong. And they range from irritability and difficulty concentrating to trouble sleeping, and the list goes on. We also know that proper use of nicotine replacement therapy can double your chances of quitting successfully. I can't say that enough. If we have something in place that has the potential to double your chances of quitting successfully, we need to be using it more. And we saw how low some of the numbers were for use of nicotine replacement therapy and the cessation medications in Dr. McChristian's presentation. We also know that the medicines can be safely combined. And actually, when we look at combining nicotine replacement therapy or the cessation medications like Wellbutrin or Chantix, actually the quit rates have been shown to triple. So we definitely want to make sure that we're doing that. The other piece that I point out, if someone isn't ready to quit, studies have shown that you can use nicotine replacement therapy or the cessation medications while you're still smoking. It's safe and it's also effective in reducing the amount that you're smoking with the hopes of getting you to that quit date. And the other thing I would like to point out is that nicotine replacement therapy dependency is very low. Often I'm asked, if nicotine is so addictive, why are you giving me this thing that keeps me smoking? Well, we know that the nicotine replacement therapy, as Cliff said, it's harmless when we compare it to the 7,000 chemicals in tobacco smoke and the almost 70 carcinogens. Also, just the method of delivery does not enforce the activation of the pleasure pathway and that addiction that we see when you inhale combustible tobacco products. So something to kind of think about. The other big part that we do when we think about the cognitive and behavioral aspects of tobacco treatment is really self-awareness and knowing your triggers. So there's a lot that we can do as far as tools and coping strategies related to those triggers. Stress is a huge trigger. It's probably the most common trigger that I hear for people when they talk about their tobacco use. And when I ask, what are other things that you do to manage stress? It's so often people don't have other coping strategies. So we work a lot on what are alternatives to tobacco use that can help you manage stress and cope. Things like really having an outlet, having good support are really important to the process. And then there's other things that we can do regarding behaviorally. One thing we recommend is this 4D. So if you're having an urge, can you delay that urge? We know that the nicotine receptors in your brain are typically only firing for about 10 minutes. If you can busy yourself for 10 minutes, that you can kind of ride that wave or urge out. That doesn't mean that a minute later you won't have another urge or trigger, but really having a plan in place for when those urges come, because they will, is important. Or doing things like drinking water, taking a deep breath, finding a distraction can be really helpful through the process. Another component that we always have to consider is relapse prevention. I can't say it enough that this is a chronic relapsing condition. So having a plan in place for relapse is very important. Typically, we focus on self-management strategies around your triggers. So can you avoid your trigger? Is there a way to alter your response to your trigger? So typically that's around what are you doing to manage your stress? And then what are alternatives to using tobacco when that trigger is in place? So whether it's nicotine replacement therapy, having your support person do something to distract you. There is a oral fixation component often with tobacco use. So is there something else like a straw or a healthy snack that you can get in your mouth as opposed to a cigarette? And then lastly, looking at slips versus a relapse. So a slip is smoking 1-2 cigarettes, not returning to your typical tobacco use pattern, as opposed to a relapse, a full-blown return to your previous use pattern. And really framing a slip as it happens, it's a mistake, but it's not a failure. What happens after the slip is really important. So we want to get right back to our quit plan. So in summary, quitting is a process. It takes time and grace and support. Nicotine replacement therapy and cessation medications can really, really help. I cannot stress this enough. And I've worked with people that have told me, I've tried everything. Typically, they either weren't dosed correctly or they needed some combination of the medications based on their tobacco use. So working with a tobacco treatment specialist and your clinical providers to determine what's best for you is where I would start with that if you've tried everything and nothing's worked. And then knowing your triggers and your coping strategies. And lastly, getting support. You do not have to do this alone. There are people that are trained to do this, and we're more than willing to support you throughout the process. A few resources to help with quitting. Of course, the University of Michigan and mHealthy's Tobacco Consultation Service. That is my program. This is a free program that is open to anyone. You do not need to be a University of Michigan patient or have any affiliation with the University of Michigan. We just want to help people quit. Our program is free. With COVID, it's done either over the phone or Zoom right now. And essentially, it's a 6-week program geared towards half of the time we are working to build your quit plan. So if you're not ready, but you have that desire to quit, we can support you. We can develop a quit plan. Typically, we like you to set a quit date somewhere between the 3rd and 4th session. And then after that, we work on some relapse prevention and maintain follow-up with you for 6 months, because we know the nature of tobacco dependency. Relapse may be a part of this process.
So Elena, just to quickly interject, I think there might be people on who are just waiting for this slide. What you're saying is, call us, we can help. We're here to help. And that's for anyone on this participating here, any friends they have. It doesn't matter if they're in Tel Aviv, Canada, or Canton, Michigan, correct?
That is correct, Mario.
So go blue. That's all I've got to say. Okay.
Yeah.
So,
okay.
but keep going. I'm sorry for interrupting.
Yeah. Oh, no worries. I'm almost finished here.
Yep.
So our program is free and open to anyone, even in Tel Aviv. The Michigan Tobacco Quit line, I use Michigan specifically, but 1-800-QUIT-NOW, if you're outside of Michigan, will get you to your state quit line, is another wonderful free resource. They have phone counselors that will work with you on a quit plan. They also have a text message program. And the nice thing about the quit line is that they do, because of some of the wonderful work Cliff has done, access to free nicotine replacement therapy. So they will directly mail to the nicotine patches. I believe sometimes they have access to the gum and the lozenge as well, but they'll mail that directly to your home. So I've worked with people that have entered our program, haven't had coverage for nicotine replacement therapy, where we've referred them to the quit line. They've continued to work with us and work with the quit line to make their quitting a reality. 2 other really good resources. Smokefree.gov is a great one-stop shop for a lot of education and information about health impacts of tobacco use, support services. And they have, if you're into apps for your phone, they have this Quit Guide app and a Quit Start app, where if you're thinking about quitting and need some motivation, the Quit Guide app can help. And then if you're ready to have a quit plan and start that process, the Quit Start app is your option there. Lastly, Nicotine Anonymous provides free support groups online, over the telephone, or in person for anyone that is working on quitting. With COVID, there's not a lot of in-person options, but the telephone support groups, they have multiple times per day. It follows a 12-step program, and it's a very nice support as you work through quitting, thinking about what you need long-term to maintain your quit. So that here's my contact information. Like I said, we're here to support you. My email's there too. If you just have a question or are just maybe not ready to make that call to enter the program, I would love to talk to you about any questions or any ways that we can support you or your loved ones through the quit process.
Thank you, Elena. And we're going to zip through these questions, and know that, again, this is being recorded. All of the PowerPoints will be made available, on the recording. I'll try to get them posted on our website. Okay, some of these questions, but some of them aren't related to our presentation. I would like to get a book, how do I request the complimentary copy? You had to have participated in the family forum with Dr. Anna Lemke, but I will tell you, if you reach out to me, I can sometimes pull a rabbit out of a hat and get you a book. So Monica, if you reach out to me, I'll put my, Angela, if you could put my email address in the chat feature. Monica, if you reach out to me, I'll do what I can to get you a copy of the book. The name of the podcast for our meeting next month is Recovery Survey. If you Google Brett Morris Recovery Survey, he pops up. It's tremendous. We've got some really good questions here. There, Brandon answered it. Let me keep going. Why aren't the tobacco companies required to list all the ingredients in a cigarette, just as food and beverages are over-the-counter drugs and supplements that are ingested? What, you guys have an answer for that?
Well, I can give you a couple of answers there, Mario. It's a great question, because it's so logical to wonder why something that we've been describing as having thousands of chemicals in it, being highly addictive, and giving so little information to the public, to consumers, about that information. And the reality is, number one, the tobacco industry lobby is extremely influential. And for decades, if not more than decades, it has really determined what happens or doesn't happen in Washington, D.C., in Congress. They have just stopped so much of the effective measures that we really could use to support public health. And they do the same now in challenging the U.S. Food and Drug Administration, which in 2009, under President Obama, for the first time gained jurisdiction to regulate tobacco products, including cigarettes and e-cigarettes for health and safety. They've sued the Food and Drug Administration to stop them from requiring stronger, including graphic health warning labels on cigarettes. We're still waiting for those to emerge. They were supposed to have gone into effect, and I'm telling you, the right year, in 2012. So 10 years later, we're still trying to get the courts to finalize all of that. So this is why you don't get more information provided like that. There should be package inserts. There should be more information on the pack. There should be more information on ads. And this is if you even allow any of that stuff to be out there at all. But given that it is, the public requires, a lot better education about it. And the cigarette companies have just not been compelled yet to disclose everything they should in these forms. Mario, you noted early on that there was litigation against the industry, and it required them to publish those ads for a period of time, saying that under court order, they had to provide a lot of information about, for example, the addictiveness of their products, the fact that they manipulate those products to cause and amplify that addiction, that secondhand smoke is dangerous, that it's bad for women who are pregnant and their babies, et cetera. And that happened because in the late 1990s, under President Clinton, the U.S. Department of Justice filed a racketeering action against Big Tobacco, a RICO action, that was finally decided in 2006. It took a number of years and then was on appeal for a bunch of years. But finally, a federal court ordered the companies, as part of having lost that lawsuit, to then run these series of ads for a period of time. But it was time limited. So they're not doing that right now. But for a while, at least, that was out there. But that's kind of your larger picture around all of this. And what it points to is the need for all of us to keep at it, to keep holding them accountable, keep educating each other, keep educating the public, and continue to be in touch with our public elected decision makers to try to help them do the right thing.
To that end, Cliff, somebody sent me an anonymous text. This information should be given to people entering treatment. As someone who started smoking in treatment, emphasizing in, I may have thought twice about it had I known any of this. Ammonia in cigarettes, ugh. Okay, so anyway, let me keep going here. Will any of our guest speakers describe the mechanisms by which smoking cessation improves treatment outcomes for other SUDs? Dr. McChristian, that might be one for you if you've got a quick answer for that.
Yeah, thank you so much. I was thinking about that one. And while I don't have the specific data that would answer that question, I do hear this quite a bit in the groups that I facilitate. I think that oftentimes smoking, it becomes part of a coping mechanism that, as Elena was mentioning, some people smoke for decades and they learn that this is the way that they're able to cope with stress and anxiety. And when they're allowed to smoke in treatment, they still rely on this kind of ingrained coping mechanism. But for our group, those people who do quit and stay quit, then start integrating more of the other coping mechanisms that they're learning, like, for example, to address their other drug of choice that brought them into treatment. So it becomes more of muscle memory for them to use, for example, deep breathing or meditation or mindfulness instead of just going out to have a cigarette when they're stressed or overwhelmed. And so I think that part of the mechanism there is that they are using their skills that they're learning in treatment to help prevent relapse instead of just going to smoking a cigarette when they're dealing with stressors.
Okay.
But that's just a guess.
Okay. Are any facilities offering the ENDS products to participants who do not want to quit nicotine altogether?
Yeah, I think I answered this question in the chat, but I do want to say that I haven't heard of programs offering ENDS. I do hear of quite a bit of clients using e-cigarettes that have been provided or recommended by their physician to quit smoking.
What I would just add there, Mario, excuse me, I'm sorry for interrupting.
No, that's okay.
This is an example of where different systems, different regulatory systems, different countries are approaching this differently. So Carabelle is correct. I'm not aware that that's been formalized in any treatment setting in the United States. If you look in the United Kingdom, so England, Scotland, Wales, et cetera, you see a very different approach where e-cigarettes are regulated very carefully in a way where they're sanctioned for sale not as medicinal products, but as consumer products for use by smokers who otherwise can't or won't quit nicotine entirely to switch from cigarettes down to e-cigarettes to help them reduce their harm and eventually, ideally at least, quit those. They also have a pathway by which healthcare practitioners in the UK can actually prescribe e-cigarettes and advise their patients to use those where it's determined to be for them the best option. Again, turning to people like Elena, who would work on a client by client basis and be able to do. So that's what they do there. I don't know if we're moving in that direction here, but this is something that people can consider. And again, when I was with the American Cancer Society, we did advise people then for those inveterate smokers who are dependent on these products that again cause the death of 1 out of 2 long-term users. If you don't want to quit nicotine entirely or simply find yourself unable to, and FDA approved medications haven't worked for you, then turn to something that is going to be substantially less harmful but give you what you need. Meet the person where they are, and that would be something like an e-cigarette or a lozenge or a pouch, non-combustible forms of delivery.
So we're going to keep answering all these questions for 2 reasons. Despite us going over our time limit, the one reason is they're interesting and great questions. And the second is, as I've mentioned, we're recording this. So if you have to go, you will at least be able to go back and reference the answers to these really good questions, okay? What other types, and Caravella and Elena and Cliff, if you've already answered these questions in the chat feature, I'm kind of going from north to south. So just tell me answers already in the chat feature. It will have been recorded in the video that's being made. What other types of medications are most commonly used in residential treatment centers? How do you pronounce that? Verinus, how do you pronounce that, Caravella?
Varenicline.
Varenicline interfere with any other meds? If not, why is NRT the only medication being offered for smoking cessation? And regarding AB 541, who pays for the tobacco use treatment?
Yeah, so varenicline and bupropion, or Wellbutrin, are also offered in substance use treatment programs. Of course, they need a prescription, and they do have some contraindications for people with specific mental health diagnoses. So I always tell people to make sure to talk to your doctor if you want to try either of those medications. And AB 541, while it is giving a lot of insight and requirements to increase services, believe it or not, it's asking programs to do that without any financial support. So no, there's not any direct path of how programs will pay for the treatment they'll provide. So I think that will again lead to a lot of variability on how programs meet that criteria.
All of these questions are good. This one, does Nicotine Anonymous allow people who are using NRT to quit attend meetings yet? So I know where they're going with that. Anybody know the answer to that?
I can speak to that.
Okay.
So yes, they do. And they do. I know from working with people that were using nicotine replacement therapy that did. So yeah, and it wasn't a big thing that came up that nicotine replacement therapy was being used, because again, I think it was more so related to the non-addictive nature of the nicotine replacement therapy products, that wasn't an issue. And then more so with that, I'll say at tobacco consultation service, it has been few and far between where we've seen people actually addicted to nicotine replacement therapy products. But I've worked with a handful of people trying to get off of the nicotine gum after years of use. No real health concerns. It was more of a financial concern to get off the nicotine replacement therapy, but Nicotine Anonymous definitely welcomes people that are using nicotine replacement therapy.
Okay, and do any of these resources for quitting support people who choose to switch to vaping or e-cigarettes to quit cigarettes?
So I can speak to our program at U of M, not so much to the quit line. We've worked with people that have switched to e-cigarettes and vape products. As a tobacco treatment specialist, and I've seen some of the comments, I know that we do have great concern about the e-cigarette products and vapes. When we think of harm reduction. So what I would say to that is that, again, trying to meet people where they're at. And I'm sorry, my baby's in the background crying right now.
That's okay.
I think she just woke up. So thinking about that is wherever you are, we're willing to work with that. So I've worked with people that have quit tobacco. They're using a vape. We've worked with people that come in specifically because they're vaping. Because oftentimes what we see is people will switch the product, but they continue to use, again, because the way the nicotine is being delivered, it's reinforcing the addiction. So trying to get people to switch over to the nicotine replacement therapy product as a plan to eventually wean them off completely is our approach. But understanding for some people, total cessation of all products is not going to be an option, and it may be that they're using the e-cigarettes and the vape. So we try to provide some education on what we know are some of the health risks or health concerns related to the cardiovascular impact, where we see inflammation of some cardiac cells with the use of some of those products.
Okay, my email address is up there for the person that wanted information on Dopamine Nation. That's Dr. Anna Lemke's book. This has been a very informational, engaging presentation. They appreciate it, and thank you all for sharing time and educational material with us again. The sharing of educational information does not stop here. All of this will be located on our website. If any of you want more information, you're having trouble connecting with Elena, you want to connect with Dr. McChristian or Counselor Cliff Douglas, just reach out to us at our website, okay? Do any of you know if Chantix will be back on the market? Don't know if I pronounced that correctly, but either Caravella or Elena, you want to address that quickly?
So I don't know if it will be back on the market. I know it is available, and I've worked with people that have gotten it. So I don't know, Dr. McChristian, can you maybe speak to that? But and I think there was a comment in the chat about the FDA has allowed APO varenicline to be distributed in the US. So Carol might know a little bit more about it.
Mm-hmm. Yeah, so what happened was Chantix in specific doses was recalled because they found some substances in it that are associated, that have carcinogenic properties. Not all doses, just some doses. And I think my understanding is that there is some people who continue to prescribe it or allow their patients to take it because the chances of, it being dangerous versus smoking kind of are outweighed by people smoking and the carcinogenic impacts of that. So more needs to be known for sure, but it seems like people are able to use Chantix still as long as they speak to their provider and know those risks.
I wanted to read this one comment. I hope we are not moving in the direction of e-cigarettes. They may be less harmful, but they are in large part being manufactured by tobacco companies, meaning they will be more and more harmful. Use FDA-approved medications. Do not encourage use of non-regulated, dangerous products. I will not give up on this. Anybody want to comment on that?
Or it's a thoughtful comment, and I appreciate the issue being raised.
I thought so too, Cliff. To
Sure,
be honest.
sure. And this is the challenge that we're all struggling with here. I've noted the UK example. They've worked through it in a different way, and they've gotten to a place where their healthcare system works closely on this. One thing that I think is important to emphasize, and I think I may have noted a comment about this in the chat, which is that when any of us talk about switching from combusted cigarettes to non-combusted, vape products or other less harmful versions of nicotine delivery, ideally the ultimate objective is to switch completely. The ultimate objective is perhaps to stop everything, to stop all use of nicotine if one is able, but short of that, to at least completely switch off of cigarettes, although in real life, a lot of people who have smoked and then vaped will find that there's a transition period. So we understand that meeting them where they are will, in some, if not many cases, involve them dual using for a period of time, but ultimately it should be the very clear and explicit goal of completely stopping burning anything and inhaling it into your lungs. So that's one thing that I think concerns people rightly. When it comes to the tobacco industry's involvement in some of this, and I think people are clear on where I stand about the accountability of the industry and their lack of trustworthiness, this is where the FDA comes in. And not to go too deeply into the technical side, but for those of us here who work on this, we're familiar with it. The FDA is reviewing applications for every single e-cigarette on the market. It's called the pre-market tobacco application process, or PMTA process. And what they're leading to is they have been denying the applications of literally millions of these applications, so that those products are going to be, by law, off the market. They should not be made, they should not be available. They will only authorize those under careful scientific review that they determine under the statute as being APPH, or appropriate for the protection of public health. In other words, without much liability to kids, but demonstrated benefit to those adults in the ways that we've been talking about. So what we're getting toward is a new phase, we hope very, very soon, where that the only e-cigarettes legally sold in America have been reviewed and authorized for sale and marketing by the Food and Drug Administration with appropriate information, with appropriate control over the product, including the delivery of nicotine, whether there are any flavors in there, and thus far they have said no. We'll see if they authorize any flavors that are deemed helpful to adults trying to stop smoking, but not posing risk to kids. And once we've entered that phase, very soon, we hope this year, that'll be more tantamount to the regulated pharmaceutical marketplace. And so the idea here is industry must be tightly regulated. We shouldn't trust them. We need to not trust and verify, right? And so that would be the response to the very legitimate concern about these products being produced by industry, and ensuring that we people, we consumers, are protected and served, you know, to the greatest extent possible in support of our personal health and the public health of the nation.
Comment in the chat feature, we are also seeing that people who use e-cigarettes end up becoming dual users. Regarding Chantix, wasn't it about nitrosamines? How did the levels even compare to what's in combustible cigarettes? Regarding cigarettes, let's stay in the realm of facts and science, not opinion regarding e-cigarettes. Agree with Carol, we have not learned from our past with big tobacco. I think what they're saying is they got us once, Cliff, and since they're manufacturing these e-cigarettes, maybe we should pay more attention to that. It is factual. There is no conclusive findings that e-cigarettes result in cessation. There is evidence that e-cigarettes are harmful. How is it that e-cigarettes are even under consideration when we know that the FDA-approved cessation medications are woefully underutilized?
Yeah, this is partly what we've been talking about, and I'll return to the critical importance. And by the way, there are entire conferences that address these issues that we're trying to touch on in a few minutes. But you know, the FDA, when it's allowed to do its job, and it's a very political world around there, right, is really very capable. The Center for Tobacco Products, which is a center within FDA that oversees the regulation, the area of regulation that we're talking about, has about 1,500 employees, and the vast majority of them are doctorate level scientists, chemists, other types of scientists who are reviewing all of the applications for all of these products. And all of them, and I know a number of people there, are smart, committed individuals who are really looking out to protect people for the public health. And this is why they've been so strict about denying so many applications so far. I think we need to lower the temperature at a certain level, depoliticize this process, and allow the agency who oversees the vast majority of foods and drugs and cosmetics, that's what the FDA does in our nation. A lot of the stuff that most of us buy in any supermarket or drugstore, to do their job and finish the review process and determine what's going to help adults, but won't pose risk to youth. I think that's just so important here because we have 31 million adults in this country who are still smoking. Half of them, going back to the primary subject of our discussion, are living with behavioral health, with mental health and or substance use conditions, and finding it extraordinarily difficult to protect themselves and not only end their dependency on various illicit products, but also to help themselves get off of tobacco, which for too many of us, too many of them, is the ultimate cause of their premature demise. And this is what we were talking about earlier. We have to find every possible way to do that. And the FDA, by the way, I really do trust them. They're really in the business of trying to support us in all of this. But when you face a great deal of political pressure in our real world, that's a tough nut to crack. And they're also trying to withstand the challenges of the tobacco industry itself, as we talked about. So again, I really appreciate these sensitivities. And this is incredible that we're having this opportunity to really talk through these thorny issues. So thanks, to everyone who is weighing in with your thoughts. It's a great demonstration of some of the things that we've got to figure out going forward.
We're going to wrap it up. This recording will be made available, as I've said a few times now. Brandon, will you please send the survey out one more time? We appreciate feedback, everyone, on our meetings and on this one in particular. It'll be in the chat feature. You'll also be asked to fill that out if you don't have time to cut and paste it. There's the survey link right there. We'll email all the participants to get your feedback. And just to our guest speakers, Cliff, Elena, Caravella, I can't thank you enough. Again, to those who want help quitting, reach out to the University of Michigan Cessation Program folks. That was on Elena's last slide. How to access help. You can always access help through us at our website. Just reach out to us at Washtenaw Fan. Say, please give me that information again, and we'll make sure you get whatever you need. So with that, we're going to call it a night. I apologize to everyone for going over, but I think it was time well spent. So thank you, everyone. Really appreciate it. We'll see all of you in May, hopefully. Okay, take care.